Good afternoon, everyone. I thank Shirish for inviting me to be part of this IC course. Coming back to amniotic membrane for pterygium surgery, again, uh, when we look back to the indications, when we have a large defects created in a double-headed primary pterygium or in a thick or a very big fleshy pterygium, then where the tissue is not adequate, then we use amniotic membrane, or in a recurrent pterygium or a pterygium associated with symblepharon or fornix shortening, where we need to have a huge amount of tissues, and those who may require future glaucoma filtering surgeries where we need to preserve the conjunctiva. That's the most indications. As far as the amniotic membrane is concerned, the important properties is the basement membrane and its avascular layer, which helps in as a good tissue for replacement of the conjunctival autograft. So the basement membrane properties which facilitate the migration, adhesion and differentiation and prevention of apoptosis to these epithelial cells, and the avascular stromal matrix contains various proteins that suppresses the TGF signaling, proliferation and myofibroblast differentiation of normal myofibroblast. This helps in reducing scar and fibrosis during conjunctival surface reconstruction, and lack of immunogenicity is the other important thing which we have. When we look at principles of AMT, it's basically the inlay graft technique where AMT is tailored to the size of the defect, acts as a scaffold for the epithelial cells and it merges with the host tissue, and it is secured with the basement membrane side up. So whenever we put an AMT, we need to check whether it is the stromal side up or the basement membrane side up. In an overlay patch graft, the AMT is used as a biological contact lens, and it protects the underlying healing surface. And filling is not generally used only in case of a complications like where you have a scleral melt and you want to cover up this, we use a fill-in layer technique. So when we look at the techniques of AMT, pterygium excision with amniotic membrane graft, usually done along with fibrin glue or with sutures. As an adjuvant, like you also combine with mitomycin C. We also have a combined approaches where we commonly use in a tertiary care center where AMT is used along with conjunctival autograft. This is again with fibrin glue and with sutures. So going back to the techniques, where as a primary pterygium, we can just, after excision of pterygium, you replace this area with a amniotic membrane transplant, and you can either treat the edges with mitomycin C or we can leave them. The second technique is where we combine the AMT along with conjunctival autograft. So where you wanted to, the area is so big, so we are not able to cover up the entire bare sclera, so that is taken care by the AMT. So the amniotic membrane, the conjunctival autograft is overlaid onto the amniotic membrane, and that takes care. So there is also a technique where when you have a large epithelial defect, you don't restrict the amniotic membrane only to the bare sclera. You can also extend that into the corneal epithelial defect, so that in the postoperative period, the corneal epithelial defect healing is also much faster. And in case of conjunctival autograft for a double-headed pterygium, you have enough tissue, you can split the conjunctival autograft and overlay it onto the AMT. So this is most commonly we prefer these three techniques, which are more because in a tertiary care centers, when patient comes with a very high, mostly with the recurrent pterygiums or in case of a large pterygium, this is the most. So this is the pictures which show the various steps. Probably it's best seen in the video. So this is a large fleshy pterygium which is covering up over to the visual axis. So we excise the entire pterygium and make sure there's no fibrous tissue is left. As far as the bare sclera is concerned, we should avoid as much of cautery as possible, because the cautery can cause a lot of necrosis and all that. So here I'm taking up the conjunctival autograft from the other side, and the entire bare sclera is covered with amniotic membrane. As I said, this one has a large epithelial defect, so I'm also covering up the corneal epithelial defect. Only important thing, when you tuck in, you have to make sure the amniotic membrane is well tucked under the edges of the conjunctiva which has been cut. So after you stick with the fibrin glue, you can excise it so that you have the complete bare sclera and the corneal epithelium is covered with the amniotic membrane. And as far as the conjunctival autograft which you have already prepared, you can take the tissue and place it. So even though there is no chance here, as you know, this is a large area, so there is no problems associated with retraction of tissue and all that, because the epithelium would start growing and cover up those areas. So this is where in a large primary pterygium, and this is a condition where you have a double head pterygium, again the same process as I said. We excised both the pterygia, and the amount of bare sclera to be covered up in both areas could not be managed with the conjunctival autograft. So here this patient also has a suspect glaucoma, so we could not take the superior bulbar conjunctiva. So here we have divided the AMT into two parts, and it is covering the bare sclera and part of the corneal epithelial defect, and this is secured with fibrin glue on both sides. So important thing is make sure the AMT is tucked under the conjunctival edges. And superiorly I am taking up the conjunctival autograft and dividing them. So there are two options. We can either include the conjunctival limbal some of the limbal cells. In case of recurrent pterygia, as Dr. Shirish already said, you try to involve some of the limbal cells, but if it is in a primary pterygia, it's not required to involve the limbal stem cells. So you can split them and spread it up. So when it is a large epithelial defect and with AMT, you can also place a contact lens for the initial period until the epithelium heals. So these are the results which are really encouraging just with AMT and with mitomycin. And the most important thing, there's a study which looked at the recurrence post AMT is the inflammation which is occurs at the graft host junction. So if the inflammation is severe, then the recurrence is very high. So they looked at what are the causes for the recurrence and for this inflammation. Most commonly the cause was the sutures which they have used, and if you can pick this inflammation in early postoperative period, you can avoid the recurrence. So this is very important. This recurrence this inflammation usually occurs in between 3 to 4 weeks of time. So you should make sure this patient is seen at that time, and if you can manage this inflammation, the recurrence can be reduced. So in this study, they found that in subconjunctival triamcinolone, if you inject in these cases, the inflammation could be reduced. So here this is a case where the inflammation was almost negligible, they didn't have any recurrence, but here they started developing the inflammation at the graft host junction, so they injected the triamcinolone and that could completely avoid the recurrence. But in this case, in the post AMT, they started getting the recurrence. This patient did not get in triamcinolone, so you can see this patient already had a conjunctival recurrence at 2 months follow-up. And other complications which were seen is the pyogenic granuloma. So coming on to the evidence to see is conjunctival autograft is indicated or we need to go for AMT. So this was a large scale study. It is like cake for me. Just before coming here, I just wanted to look at review of literature, and this is just published in here. And for a good evidence, Cochrane reviews are the best evidence. What is evidence? Number one evidence is the randomized clinical trials, and a meta-analysis is where they look at all the clinical trials that are available which had compared just only conjunctival autograft versus amniotic membrane transplants. So this study looked at almost 22 randomized control studies, and they had almost 1947 eyes of 1866 participants, and this were the distribution of AMT. They looked at what is the recurrence immediately at 3 months and recurrence at 6 months. If you look at only at conjunctival autograft at 3 months, the recurrence rate is 0 to 16.7%, whereas AMT it was 4.76 to 26.9%. So we compare this to using what is called as risk ratio. So comparing conjunctival autograft, is AMT better or not? So it says that with conjunctival autograft, the AMT is lesser compared to conjunctival autograft. It says the risk ratio is 0.87%. It says it is 13% better than conjunctival autograft. We usually minus 100 minus this, it will give us the percentage. So it is, and with the confidence intervals, it is crossing 1. If the risk ratio is 1, it means there is no difference. It has already crossed 1, so that means it is not clear-cut evidence that at 3 months using either conjunctival autograft or AMT may not really helpful. So this is what, look at the results. So this is the meta-analysis report which shows that the risk ratio is equivocal. So either doing conjunctival autograft or amniotic membrane is not much of difference. So can we come back and look at what happens at 6 months? This is at recurrence at 6 months. They looked at the conjunctival autograft recurrence was 3.36% to 16.7%, whereas with AMT it was 2.6 to 42.3%, which is very high. So whereas the relative risk ratio is very, very encouraging, it is only 0.53%. That says conjunctival autograft does very well On a long term, it is almost 47% less recurrence compared to AMT, and the confidence interval does not cross 1. So that is, the evidence is very in favor of conjunctival autograft compared to amniotic membrane transplant. So this is what the complete graph shows, and it is not crossing 1. So ideally, conjunctival autograft would be the primary choice for treatment of primary pterygiums. The AMT should be used as an adjuvant in case of a recurrent pterygm or a large grafts. So take home message is, avoid sutures wherever possible. Use fibrin glue. The results are extremely good because it reduces the inflammation in the postoperative period, and the primary choice should be conjunctival autograft. Use AMT as adjuvant to conjunctival autograft, just not only AMT and mitomycin. Treat the inflammation in the postoperative period and use MMC in case of recurrence. Thank you.